Yes, ma'am, we are live now.
Okay, thank you.
Recording in progress.
Good evening, doctors. I'm Dr. Namra Sheikh, medical advisor with Emcure Pharmaceuticals. I welcome you all to on this digital platform for another exciting session on no thrombosis workshop series in acute ischemic stroke. It gives me immense pleasure to welcome our post director for today's session, Dr. Subhash Kaul, sir. Sir is senior consulting and stroke specialist at the KIMS Foundation Center, Sikandarabad. He's been in the faculty for 27 years at the Nizam Institute of Medical Sciences and has been the former professor and HOD and dean at NIMS. He has the credit of more than 120 publications in national and international journals. He's been the principal investigator of various national and international clinical trials and has been the past president of AP Neuroscientists Association, ISA, and IAN. We welcome you, sir. Thank you for being on board today.
Thank you. Thank you.
I would now like to welcome Dr. Meenakshi Sundaram, sir. Sir is the senior consultant neurologist at Apollo Hospital. He has the credit of over 20 years of experience in neurology and has presented papers at various national prestigious forums, has received the Best Research Paper Award at the IAN Lucknow 2002. He's been the principal investigator for various international trials and has contributed to many books on neurology. We welcome you, sir. So we have three eminent speakers today. We have with us Dr. Jaya Sankar. He has attended the ex-mint and successfully obtained diploma in ischemic stroke intervention in 2023. He has done postdoctoral fellowships and diploma trainings. We welcome you, sir, today. Our next speaker is Dr. Debayan Datta. He is working as consultant neurologist at Shalby Multi-Speciality Hospital. He is a member of the IAN, the IAAN, the MDSI, and International Parkinson and Movement Disorder Society. We welcome you, sir, today. Thank you for being on board. Next speaker for today's session is Dr. Shishir Pandey. He's working as consultant neurologist at the Apollo Hospital, and he has a credit of publications in various national and international journals and poster presentation in national and international conferences. We welcome you, sir. Thank you for being on board. Now, without further ado, I would request Dr. Subhash Kaul, sir, to continue with the workshop.
Yeah, thank you very much, Dr. Sheikh. So I think everybody knows about this program, which has been going on for more than a year now, in which we discuss the cases and discuss what are the challenging aspects of these cases. It gives a good opportunity to the young neurologists for presenting their work and for mutual discussion, and all of us learn from that. So I think, should I, the way you presented Dr. Debayan Datta is the moderator, is that correct? Or he is the moderator, or he is presenting a case?
Speaker, sir. He is the speaker.
He's a speaker. So all the three are speakers.
Right.
And okay. So then, so that means today we don't have any separate moderators. We have only three speakers and myself, right?
Sir, we are expecting Dr. Meenakshi Sundaram to join.
That's fine. That's fine. So therefore, then I would request Dr. Jayashankar to start and present his case. Dr. Jayashankar, please.
Hi, sir.
Hello.
I'm Jayashankar.
Hello.
And I thank Emcure for giving me this opportunity to present in front of such senior faculties in neurology, sir. And I think, am I able to share? I don't know. Okay, shall I share my PowerPoint? This thing?
Please do, sir.
Okay, okay. Is it visible?
Yes.
Okay, okay.
Slideshow. Make it slideshow. Big one.
Yeah, I have. Is it okay, sir?
Yes.
Okay. So basically, I am discussing one simple case of posterior circulation stroke. So going straight away to the presentation, and it is about a 76-year-old female who was brought to our emergency room, came referred from another hospital, and the history was like she developed right lower limb weakness and left upper limb weakness. So a sort of cruciate type of weakness which was sudden in onset. And prior to that, she was having on and off vertiginous sensation and on and off unsteadiness of while walking for the past 1 week prior to the onset of this acute illness. And she was on symptomatic treatment for that initial 1 week period. And she was initially evaluated in outside hospital on that second part of the illness. And she was diagnosed with the acute ischemic stroke, and she had infarct in right cerebellum and left thalamus. So at that point of time, so probably she is having brainstem involvement also because she is having weakness. And probably she is having a large area of ischemia involving the brainstem, the cerebellum, the thalamus. So whole of posterior circulation. And it was on that basilar artery is not visualized in MR angiogram. And since the patient was in window period, she was thrombolized with injection time to place, and she was referred for endovascular care. So at arrival, she was conscious and oriented, was having nystagmus, a bit of dysarthry, and limb power was like right upper limb, right power was almost more than 3 node limbs, and some sort of quadriparesis she was having, and there was truncal ataxia along with that. So this was the imaging which was done outside. So she was having a right cerebellar infarct and left thalamic infarct. The brainstem was radiologically almost preserved, but she was having some sort of pyramidal involvement also. And the angiogram, this angiogram was done in our hospital so that we can see the posterior circulation is involved. We can see the vertebral artery, left vertebral artery here. So right probably will be hypoplastic, and from basilar it is not visualized properly. In the source imaging angiogram we can see left vertebral alone. So it will be dominant, or the other will be hypoplastic and carrying the blood to the basilar, but basilar itself is absent. Here this is a large pica, this is basilar. It is not fully opacified, but the top part of the posterior circulation, that is basilar bifurcation, we can see the PCS coming. So that the upper part is filled somehow, even though we are not seeing a good supply from the posterior communicating artery. So somehow blood is reaching there, probably through some stenotic vessel or some small posterior communicating artery. Here we can see left vertebral, and this is SWAN imaging, which is showing a blooming in the occluded part of basilar artery, which means patient is having some thrombotic occlusion, probably RBC rich clot. the same in flyer also there is non-opacific loss of flow void in basilar artery. CT angio was done. So we can see one vertebral, the other vertebral, left pica we can see, and there is a gap here, and reformation of the distal basilar. So somehow blood is reaching this to this point, and this part will be ischemic. That is why we are having a thalamic stroke. So here will be ischemic. Here maximum ischemia will be there. So we didn't take up for a mechanical thrombectomy initially because patient quickly improved. Within hours, patient improved. So let's go through some basics of basilar thrombectomy. So basilar stroke overall 80% dependency is the rule. So it is a very devastating illness. Collaboration has made a posterior circulation NHS score because some of the points like dysarthria, or ataxia, dysphagia, cough, etc., is not stressed in the other NHS score. So posterior circulation stroke has got its own NHS, and posterior circulation aspect score has been proposed, has been used, and a very bad outcome when it is very good outcome when it is more than 8. And another important parameter for assessing the area, the core, is Pond's midbrain index, which gives maximum of 2 in each half of Pond's and midbrain. So it will be total score of 8. So maximum score will be 8, in which both Pond's and midbrain. So if it is less than 3, very less mortality. And about the evidence, we have Bauche and attention trials, which has been released recently. Before these trials, there was no much evidence. Attention trial 0 to 12 hours was the window. Bauche was 0 to 24 hours was the window. These two trials took the window out of beyond 6 hours, up to 1 day. And the meta-analysis of these two trials has confirmed significant improvement in functional outcome for the mechanical thrombectomy group. And mortality among mechanical thrombectomy is very less, even though symptomatic hemorrhage is more in mechanical thrombectomy. These are the posterior circulation aspect. We can give 2 points each for Pons, midbrain, and 1 each for 1/2 of cerebellum, occipital lobe, and thalamus. Pons midbrain index, here we can see we are using contrast source imaging. Here we can see 1/2 of Pons and another half of Pons, 50% is involved. So arbitrarily it corresponds to the DWI changes. This is diffusion imaging. So we can use diffusion imaging also to calculate Pons midbrain index. Bauche trial was very positive. 40, the outcome was very good in thrombectomy group, even though symptomatic hemorrhage is more. Both mortality and functional outcome is better, like 46 versus 24. So okay. So basics and best was the previous two trials, which do not show any significant benefit. But after that, attention and Bauche came, which took the window from 6 or 8 to 12 and 24 hours, which showed a very good outcome for mechanical thrombectomy. So after these two trials, the benefit of thrombectomy has been very much established. So coming back to our case, just going through the aspects of thrombectomy, right side I told it was very much hypoplastic. We can't go through that. Left at the origin there was a very tortuous anatomy. So we waited because since the patient improved to power more than 4/5, so very less NIHs. So we waited. But what happened is patient deteriorated on day 3 with the new infarct. So the aspects changed, the NIHS changed. But at that point of time, bystanders like relatives were not willing for thrombectomy at that point of time. But once again, patient had fluctuations, improved, and once again deteriorated on day 5. So we once again gave the option for endovascular therapy, but the problem here is regarding the aspect, a low aspect, a high Pons midbrain index, and NIHS also went high. But the rate at which the NIHS went high was very quick, so that we probably have a window to bring back the patient to the previous state. So we did endovascular therapy. So angio showed a cutoff at initial part of basilar artery, and we can see a reformation of the basilar artery here. So somehow his blood is getting to this point. So what we can do is to navigate to this part and try pulling out the thrombus, because we have already seen blooming in the mid-basilar segment. So probably patient is having a thrombus without or with underlying stenosis. So we went forward with the wiring of we passed the wire through the basilar artery. Then we did a single pass of thrombectomy so that the clot from this part was gone, but the residual stenosis was there with very less filling beyond the mid part of the basilar artery. So we went for a stenting at this point, because here there was a tight stenosis, and in that area we put a coronary stent of size 2.5 into 1.5 centimeter stent. And after putting the stent, the flow very much increased through this area, so that the distal filling was improved. So here there was no residual clot. Only this part was our final residual deficit. So when we corrected that with the stent, everything we could see both superior cerebellar, one of the PC we can see. Here some anomalies there. Right ICA we can see, and a large left pica probably supplying the upper middle part of cerebellum. So a ICA in this side is not seen, and we we avoided pica. Yeah, so that was the angiographic outcome, and patient became conscious after 1 day, and she was having a right hemiparesis after 2-3 days, and at discharge power improved to 4/5, but there was severe ataxia, so that she was not ambulant. She was so much ataxic, even sitting will cause ataxia, and some dysarthria, bulbar dysfunction. So we have to put Ryle's tube, catheterize, and send the patient home. But from that point, patient actually improved to this state. This video was taken this evening. I asked her to send one video, so she sent me. This is after 2 months. From stuporous, she improved to this state. Even though we took up like 5th day of her illness, but on that 5th day, she had a drastic elevation of NIHS, so that change we could reverse to that previous state, so that she improved from that point of illness. Yeah. That's all, sir. So I just want to stress the importance of like a late window endovascular option in very much selected patient, especially posterior circulation. That's all, sir.
So thank you, Dr. Jaishankar. Has Dr. Meenakshi joined or not yet? Dr. Sheikh, has has Dr. Meenakshi joined or not yet?
Sir, I think he won't be able to join.
Okay. So thank you, Dr. Jayashankar. I think that was really a very, very special presentation. Now, from what I understand, this was not a mechanical thrombectomy. This was basically a angioplasty with stenting. Am I right?
Sir, actually both, sir. We could take out a large amount of clot. We did thrombectomy first through the stenosis. Beyond the stenosis, almost towards the mid segment, there was a clot which was removed. Actually, we got the clot, and after that, there was a residual stenosis at the initial part of basilar artery.
So I think, yes. So I think the outcome is excellent. And as you have said that this is, you initially did not want to interfere, but as the patient worsened at that time, you took a chance. But in both on both counts, means mechanical thrombectomy as well as stenting, I think you have gone beyond the guidelines, in which patient has benefited, of course, and that's probably the lesson. Because if you see, as per the guidelines, first of all, there are no guidelines for posterior circulation. Guidelines standing. Even for thrombectomy, the guidelines and the research is only on MCA. Now we extrapolate that to posterior circulation. So therefore, at 24 hours, all the mechanical thrombectomy ends. If you go by the guidelines, even if you take diffuse and dawn, which have extended. Even that extended guidelines also conventionally stops at 24 hours. But you have done it as late as 5 days. So I think that gives us a lesson that one can go in given situation. But I think patient was lucky also, because many times... because this patient, in fact, what you showed, there was already damage in the pons. It was not that his... there
was a diffusion changes.
But one good thing was that his midbrain was not affected. So that is probably one good sign, that midbrain was preserved. And midbrain is very important for consciousness. But the pons had gone. So that's a good thing. Second thing is that we all know that when we, in this initial phase of infarct, put them on double antiplatelet stent, they are at a risk of hemorrhage. But that also patient was once again lucky, and doctors were lucky that there was no hemorrhage. So all in all, I think it was a good case, and gives us a lesson that sometimes we have to go beyond guidelines in given situations after fully explaining to the patient. And So thank you very much. If there are any other questions from the other participants, please feel free, give your comments or questions to Dr. Jayashankar. Is Dr. Devayan Datta or Dr. Shishir, you have any comments or questions on this case from Dr. Jayashankar?
No, sir. Excellent case and excellent daring to go beyond the guidelines. I also inspired by these type of daring things.
Yeah. This is, I think, to do mechanical thrombectomy at 5th day, I think you must write it. You must write it, because then it will reach more and more people. Obviously, we cannot do it in every patient. These guidelines are basically, why are these guidelines given? They are given for the safety of the patient and safety of the doctor, because these are the patients who can bleed very massively, and the outcome could have been very bad. But we should, but in some cases they can make all the difference. And unfortunately, we don't know beforehand in which it will make difference and in which it will not make difference. That's why guidelines, rather than efficacy, the guidelines are developed towards safety. If you see any of the guidelines, they are looked towards safety. And if you see the guidelines, grade 1, grade 2, they always say benefit much more than risk, benefit equal to risk. So it's all between risk and safety. And it is thought that when you cross beyond 24 hours, there may be risk. But we should not forget that there is a chance of benefit also. And that happened in this patient. And so I think the good thing is to always closely follow the patient. And But I'm sure one ray of hope in this patient was, as midbrain was still there. If the midbrain was totally gone, then probably one would not have ventured to do that, something which is already dead tissue. But there was some 20-30% of the brainstem which was still intact, and that gave a hope. But the great thing is that you went beyond the guidelines and achieved an excellent outcome, which we saw on the video. We were also very happy to see the lady. So congratulations. Thank you very much.
Thank
So
you,
with
sir.
that, we move to the second case. That is Dr. Debyan Datta. Sir, Mr. Dr. Datta.
Yes, sir. Can I just start?
Please go ahead. Please go ahead.
First of all, I'd like to thank Emcure and all the moderators of the session to give me this opportunity to present this challenging case of a young patient who presented with an acute stroke. So let's go directly into the clinical scenario. So a 40-year-old gentleman from Jabalpur. He was businessman by profession, right-handed, with a pre-hospital MRS of 0, presented in ER with sudden onset right hemiplegia and inability to speak. His last seen normal was around 2 hours ago. And he's presented at our hospital at 3 hours. So it took 1 hour to reach the hospital. On top of that, to make things worse, he developed one episode of focal seizure with impaired awareness in the emergency. He was treated with injection levetiracetam 2 gram IV stat, but there was no recurrence. But the patient became more drowsy. After that, there was no traditional risk factor or history of prior stroke or MI, or there was no family history. He takes occasional alcohol and he smokes one pack per day. So on examination, this examination was done before the seizure. After seizure, he was fully in post-ictal confused state. His pulse rate was regular, BP normal. NIHS was 18 with a right complete hemiplegia, dense hemiplegia. Upper limb power was 0, lower limb power was 1. There was right human facial palsy. There was a gaze palsy, global aphasia, dysarthria, and right inattention. So this was the initial MRI. As you can see, the whole of the left MCA territory, there is a DWI restriction, with maybe sparing a caudate nucleus and some part of the lentiform nucleus. On the cut, just above the basal ganglia, the M4, M5 segments were there. They definitely involved, maybe some sparing of the M6 segment. However, in FLAIR, there was not much of change, very subtle little hyperintensity we could see in the basal ganglia cuts. So there was a clear-cut diffusion FLAIR mismatch, as we would have expected in a patient with stroke of less than 4.5 hours of onset. So this was the source image of MR angio. I apologize for the very poor quality. We can see the both the ICA and this is the basilar. And here in this cut, we can see there was an M1 occlusion here. Yeah, I think you can appreciate that the M1 is occluded on the left side. However, right side, the M1 we can see properly in the top source event. So in MRI, there was a left MCA territory acute infarct. The DWI aspects were 3. However, we should not take DWI aspect because most of the time it overestimates the aspect scores. Aspects should be taken in CT. MR angio showed left MCA occlusion. So then there was a time for taking a decision about the patient. So there was some point for thrombolysis, there was some point against thrombolysis and thrombectomy also. So we thought he's a young patient, only 40 years, like he's a businessman, he has a family. If we left him out of the care of the thrombolysis and thrombectomy, there will be a lifelong morbidity that could burden him throughout his life. He presented within a window period with a LVO, and there was a definite DWI flare mismatch, which means there was still a salvageable tissue in the left MCA territory, although the DWI was completely bright on the one side. However, there was some point to go against thrombolysis as the more than 1/3 of MCA territory was involved with low aspects. However, we did not rely on these aspects because this was taken in the DWI. And there was a very high chance of bleed. And there was seizure at the onset, which is a relative contraindication, not a absolute contraindication for thrombolysis. So our decision was to go for IVT followed by EVT. However, patient relatives declined EVT due to financial constraints. So we went ahead with IVT with injection tenecteplase 0.25 milligram per kg. So 1 hour post-procedure, the patient's NIHS was still 18. There was not much improvement, but after 24 hours, he had a remarkable improvement in the right upper and lower limb weakness. Right upper limb weakness was 4/5 and lower limb weakness was 4+/5. There was right human facial palsy, but there was no gaze palsy. Previously, which was a global aphasia that evolved into a kind of Broca's aphasia, was able to understand but not able to speak. There was mild dysarthria. There was no inattention. And the thrombolysis went safely without any bleeding or anaphylaxis. So this was the repeat MRI after 24 hours. Here you can see the diffusion restriction in the left MCA territory. However, there was islands of area where the diffusion restriction was not there. So we can tell that we have salvaged this part of the tissue. And in ADC also, the corresponding area was not fully hypointense. This area was completely hypointense. So there was some tissue that was still salvageable. However, as we have expected, there would be some bleed, and there was small bleed in the SWI images in the posterior putamen. But the bleed was non-threatening, and it did not, and it was a silent ACH without causing any symptom or any dropping down of NIHs. This was the flare image of the same patient. We can see the vasogenic edema that occurred around the MCA territory, which was infarcted, and there was this small hypointense area of bleed. However, on the MR angio, we can see that there was no evidence of any large vessel occlusion. The M1 occlusion that we could see in the previous images was completely gone. So in this case, we can tell sometimes with some luck, even on a large vessel occlusion, patient can do remarkably well with only thrombolysis without needing endovascular therapy. However, we would have hoped we would be happy to go with endovascular therapy, but sometimes due to financial constraints and other constraints, endovascular therapy is not always possible. So we evaluated him for the etiology, and in etiological evaluation, we could see there was a macrocytic normochromic anemia. MCV was 108. ESR HbA1c was normal. B12 was on the lower side, 105, and homocysteine was markedly raised, more than 50. TSH, ANA profile, all were negative. 2D echo and color Doppler was no. So final diagnosis was acute left MCA territory infarct. Post classification was large artery atherosclerosis, left M1 occlusion. Risk factor was B12 deficiency, hyperhomocysteinemia, and smoking. So at discharge, patient had a MRS of 2, and his NIH further dropped to only 4. He didn't have any weakness. There was mild right human facial palsy, and there was Broca's aphasia and mild dysarthria. Right upper limb power improved to almost 4+, and right lower limb power was 5/5 at the time of discharge. So we'll give some 2-3 points about homocysteine and stroke. So homocysteine, as you all know, is a byproduct of the methionine metabolism. From methionine, it converts into S-adenosyl methionine by methionine adenine transferase, which acts as the universal methyl donor. And from S-adenosyl methionine, it converts into S-adenosyl homocysteine, from which the homocysteine is developed by S-adenosyl homocysteine homosynthetase. From homocysteine, with the help of B6 and the enzyme cystathione beta synthetase, we get cystathione, from which cysteine is the byproduct, which is so the homocysteine is gets metabolized by two pathways. One is the transsulfuration pathway, one is the remethylation pathway. So this is the transsulfuration pathway, and by remethylation pathway, the homocysteine is converted into methionine by methionine synthesis, and here the vitamin B12 is helps as a active coenzyme of that of the methionine synthase enzyme, and the folic acid, which forms the tetrahydrofolate, gives up methyl group, and from 5-methyl tetrahydrofolate, it converts into a tetrahydrofolate. So whenever there is a deficiency of vitamin B12, the homocysteine cannot be converted into methionine via the remethylation pathway. So only the transsulfuration pathway goes on. However, the transsulfuration pathway alone is not sufficient to metabolize all the homocysteine. So there is a homocysteinemia in those patients. Same thing happens with the folic acid deficiency also. Because of the deficient folic acid, tetrahydrofolate is not formed, 5-methyl tetrahydrofolate is not formed. So the homocysteine cannot be converted back into methionine. So the homocysteine is associated with 3 to 4-fold increase in the ischemic stroke, and it is mostly associated with large artery atherosclerosis and venous thrombosis. About 19%, there is about 19% reduction in the risk of stroke for every 3 micromole decrease in the plasma homocysteine concentration with vitamin supplementation. Homocysteine level above 15 have a possible non-linear association with ischemic stroke. There is a 59% increase in the risk of stroke when homocysteine is increased by 5 micromole per liter. There are 5 studies which have shown an association between large vessel stroke and homocysteine level. Individuals with MCA stroke have a significantly higher homocysteine levels than PCS intraarterial or posterior circulation strokes. Risk factor for other strokes subtypes also, including the intracerebral hemorrhage. Homocysteine also increases the chance of ICH also. So there are some meta-analysis that in this meta-analysis around 5,000 patients were covered, and it concluded that the ischemic stroke those patients with ischemic stroke have a higher level of homocysteine compared to controls. Whether these modifiable risk factors remains to be assessed through larger prospective cohorts. In this another systematic review and meta-analysis, they have also concluded that ischemic stroke patients have a higher homocysteine levels than controls, and detecting hyperhomocysteinemia and reducing homocysteine levels should be explored among individuals at higher risk for ischemic stroke. So there are some case reports of homocysteine-related large vessel occlusion also. And this is a tri-ethnic cohort done in northern Manhattan, where around 3,000 patients were followed, and those patients who have a homocysteine level of more than 15 had a higher chance of vascular death by stroke, MI, or other causes than those patients who have a homocysteine level of less than 10. So any patient with a homocysteine elevation above 15 micromole which is an independent risk for the patient of ischemic stroke, whereas mild elevation of homocysteine to 10 to 15 micromole are less predictive of a vascular cause and vascular death. So how the homocysteine acts? It decreases the natural TPA activity. It increases the cell adhesion and growth promoting pathways. It also promotes the NMDR-mediated neurotoxicity. It increases the thrombin and antithrombin complex and increase volume factor level, and it impairs endothelial function and increase oxidative states. Overall, it promotes the pro-thrombotic state. It reduces the natural fibrinolysis pathway. It increases the atherogenesis, and it increases the endothelial inflammation, leading to an overall pro-thrombotic state and increased chance of other vascular events like stroke, AMI. Prevention. The VitaTops trial told the daily vitamin supplementation did not appear to overcome the chance of getting a stroke, including my major vascular events. However, in the post-hoc analysis of the stroke patients who are not on antiplatelet therapy, vitamin B12 treatment correlated with a significantly better outcome. Homocysteine reduction after folic acid supplementation were significantly higher than only vitamin B12 supplementation. Therefore, FDA has mandated folic acid fortification in foods of some parts of USA. Thank you.
Yeah, thank you. Thank you, Dr. Datta. I think that was a very good case. Can I ask other participants, other speakers, if they have any questions or comments to ask Dr. Debian Datta? Dr. Shishir or Dr. Jaishankar, any comments from you? Am I audible?
Yes.
Yeah,
Sometimes
please.
we see like this, sir. When patient is being referred for thrombectomy, when we do the angio, some of the vessels might have been opened like after thrombolysis.
Yeah.
So we just do like we wind up. So we used to see that, especially if the clot burden is less and if it is very clot soft
Yes,
embolic.
you are right. You are right, Dr. Jaishankar. This patient had come in the window period, Doctor.
Yes, sir. He came within.
So in any case, I mean, suppose even if he had opted for mechanical thrombectomy within window period, we are supposed to give IV first,
Yes.
as per the current guidelines. So even if he had agreed for mechanical thrombectomy, you wouldn't have done it because it had already recanalized with tenecteplase.
Yeah.
And that is one advantage of tenecteplase over alteplase, as they say, as per the extent intraarterial trial, that the large vessels, they have higher chance of opening compared to alteplase with this. And I think this case very nicely shows that. Any other comment? I have two comments and one, actually all the three are comments only. One is that, as you rightly said, seizure is a relative contraindication. It's actually by this, it used to be a contraindication, but now if we are sure that the seizure is because of stroke, then we can go ahead. But main thing is we have to make sure that the seizure, that seizure thing is basically not in this patient. That is usually when the CT scan, when we would do CT scan and the patient has a seizure and CT scan is normal, and you don't know at that time whether this weakness is a post-ictal phenomena or whether it is because of ischemia. But when you know that there is a ischemia and patient don't have a history of seizure, I don't think at that time it is an issue. Number one. Second is that second is a very interesting thing actually what you have said, because I have been with this field for the last ever since thrombolysis started from 1995. I've seen guidelines evolving and then developing and then getting refined. So initially it was thought that anything which is more than 1/3 of the MCA was a contraindication for many years. It was a contraindication, you could not give it. But in 2018 or so, they have relaxed that. And now within 3 hours, and that 3 hours has been now extended to 4.5 hours, any degree of ischemia, even if the entire MCA is involved, either on diffusion or in the CT scan, it is not a contraindication. As long as you are within the window period, preferably 3 hours, but even 4.5 hours. Which sounds quite counterintuitive. You would normally expect that if there is an entire MCA is gone, then how will they improve? And I have discussed this this situation with many people. And in fact, one of the proponents who believes that you should thrombolyze in spite of the extent is Indian neurointerventionalist Dr. Mayank Goyal. And I had a discussion with Mayank Goyal actually a few months ago. He had come to India, that what is the rationale of doing these large core thrombolysis? Because diffusion usually does not reverse. Initially, there was a feeling that diffusion can reverse. But if you see the subsequent MRI, the diffusion does not reverse. It remains there. And yet there are some patients who improve, as your patient who has improved. And the reason which he gave and what is thought is that and I think you have shown it very nicely. You have shown it more explicitly. But the reason which he has given is that diffusion means that so much of area is affected, but it does not mean that so much of area is irreversibly damaged. There still may be some parts of brain within the diffusion area also, which may be salvageable. In your case, it was seen very nicely. But suppose even if those black holes were not in your, even then, the rationale is that there may be some area. So in other words, the diffusion, extent of diffusion does not necessarily correlate with with the ultimate clinical outcome. Now, this is a new knowledge which has come only in the last 1 or 2 years. And this is the thing which is behind the science of doing large core thrombectomies and large core this thing. And I think I'm very happy that you have shown very nicely in this patient the same thing which we are interested in. And but my one question to you is that, this homocysteine thing is very attractive hypothesis, but the intriguing thing is that all along they say that it's a known risk factor, but we are not sure whether correcting it will prevent any stroke or not. So this has been there since Vita Tops in the last 10 years. Now that looks quite counterintuitive to me but I know that is the literature. So you have shown that homocysteine damages the endothelium, causes the hypoxia, causes the polycythemia. If we correct it, intuitively all those things should get corrected and it should reduce the risk. But we are, even the guidelines say that we are not. No, they don't say we are not sure. They say it has not been shown to reduce the prevalence of stroke. So is there any new thoughts on it? You must have reviewed the literature. Is there any new thoughts that you should correct it? Is there anything like that?
No, sir. Whether there was a new argument whether the homocysteine level increases because of stroke or the increased homocysteine level leads to stroke, there is an argument of that, because many patients with high homocysteine levels also will not develop stroke in his entire in entire life.
Yeah.
So the point of treating homocysteine to it's not like LDL. We can fix a target below that.
Yeah.
You are having a less chance. So because the mechanism of the pathomechanism is not very direct. It has homocysteine affects both the large vessels and the small vessels also. Even in cognitive disorders, we say small vessel disease are associated with higher homocysteine levels. So exact pathomechanism has not been elucidated till now. So that's why the new thoughts which are coming, whether to correct it, whether this homocysteine is because of the stroke or the stroke is because of the high homocysteine levels. So
you mean which came first, chicken or the egg?
Yeah.
Okay. But anyway, I think if we find homocysteine, we should correct it irrespective of, because it makes sense, no? Although in guidelines, they don't say that don't treat it. But what they say is that it has not been shown to prevent the stroke in the primary prevention. But I think we should still treat it. If we know something is abnormal, we should treat it. But thank you very much. I think your case was fantastic. And once again, as I say, it should be published because, these days when you publish something, thousands of people all over the world benefit from it. Presentations are over and after that, nobody knows about it. So I would highly encourage you to publish this case of large. The main thing to be published here is the good outcome in the two things. One is good outcome despite the large size on diffusion, and the more important is that how intravenous thing can just completely recanalize without the need of mechanical. Congratulations once again. And now we don't have much time, but I think we would still like to have the third case quickly as a short case from Dr. Shishir Pandey, because we are always very eager to learn from each other. Dr. Shishir Pandey, over to you from Indraprastha Apollo, Delhi.
Yes, sir. Namra, please play my slide. Make it full screen. Am I audible?
Yeah.
Okay. Good evening, as esteemed guest. My case is of a present of an acute ischemic stroke present as a movement disorder. It is a one of an interesting pathophysiology that we are going to discuss. Next slide. My case is Mr. Balbir Singh Chabda. He is an 81-year-old male with presented as an asymptomatic before 9 a.m. on the 16th December 2023, when he suddenly develops a weakness of a left upper limb while communicating into the land up to the emergency department. And while in the emergency department, the patient has an episode of spontaneous painful posturing with rotation and flexion of the right arm and extension of the right leg that resolve in less than a minute without any intervention. During the evaluation by the stroke team, she had another episode of a similar kind. The NHS score was 2 of the right upper extremity, and there was an associated ataxia and dysarthria. He had a mild weakness of a right wrist extensor without any right arm drift. Blood pressure on arrival was 202 by 99. Next. This is in video. Kindly play the video. Here we show the dystonic posture of the right upper limb with a dystonic tremor along with it. Next, urgently as the symptom of the patient has started since 9 a.m. and patient land up to the emergency at 4:30 or 5:30 p.m. So patient is out of the window period. Although we have done the CT scan, we found a small hypodensity in the left frontal region. Next. And on the MRI, we would find this in large area of an infarct involving the frontal and the pre-central gyrus, which showed diffusion restriction. Next. In MRNGO, there is a no occlusion. Both the MCA and ICA, as we first of all, we thought it could be a limb shaking TIA. So we were looking to the ICA, there could be a possibility of occlusion, but it is not so much seen in the MRNGO. Next. This is lateral view. Next. And so out of curiosity, for an academic purpose, we have done the EEG along with an electrode placed on the tremulousness hand, and it shows a fine rhythmic tremor of, we show in the second last line, there is a fine tremor along with the rhythmic EEG. Next. So there is a 10 to 12 hertz right dystonic tremor, and there is a no epileptiform activity. Next. And on further investigation on 2D echo, there is a no LA clot. Ejection fraction is 60%. No cardiac cause is there for the cause of the stroke. Bilateral carotid Doppler we have done, but we found a plaque in the right internal carotid artery, not in the left, although the phenomenology in the left side. And there on the left side, there is only mild eccentric plaque in the left carotid valve, but that is not significant. Next. On a routine examination, routine workup, there is a vitamin D level is low, is 3, and the homocysteine was borderline high, it was 17. Patient was managed with dual antiplatelet, anticoagulant at the starting, and statins, and patient responded to the treatment well. And now regarding the discussion part, how these things happens and how we are going to recognize as a presentation of an acute stroke. Generally, the dystonia and the other movement disorder that happens could occur as a part of a late manifestation of a stroke. And that part of the stroke involves the gangulocapsular region. And as we know, there are involvement. There is a direct pathway, which is an excitatory pathway, and there is an inhibitory indirect pathway, which is responsible for modulating the direct pathway. And both resultant to net result is the activation of an indirect pathway, that is the inhibition of an upper motor neuron in the motor cortex. Next. Although stroke-related dyskinesia, that is late manifestation of any stroke incidence, mechanism is not completely understood, but this is postulated that it could happen after the denervation hypersensitivity at the postsynaptic level, which is a rare, although itself a rare phenomenon. Next. The most common site of isolated lesion causing that dystonic thing is the putamen, but the thalamus, pallidum, caudate, and midbrain also have been the same cause. The suggestion is to interrupt the connection between the basal ganglia, specifically to the sensory motor part of the putamen, striatum, and pallidum, which increases the thalamic drive. That is the final outcome of the indirect pathway to the sensory motor cortex, which is projecting to the frontal and the motor cortical areas. That results in dystonia. In the similar way, other studies also supported the hyperkinetic movement following the stroke result from the thalamic distribution, which in turn release the motor cortex in the indirect pathway. And this could always be explained by the overactivity of a direct pathway that could release to the dystonic symptoms. In our study, there is no infarct on the gangulocapsular region, but there is an infarct at the base of the sensory motor cortex. Maybe that could be the cause of this dystonic limb movement. Next. And in the last, as a concluding part, definitely it is a challenging case if a patient present with a form of acute dystonia as a symptom of a acute ischemic stroke. Based on our rare case and previous case reports, it was unfortunate that our patient land up out of window period. That's why we can't thrombolize. But if any patient with dystonia presents with an extremity weakness, facial droop, and dysarthria, if it is he or she is in a window period, definitely we would go out with the thrombolysis. Next. These are my references. Next. Thanks.
That's nice, Shishir Pandey. For your thank you slide also you said next, but that was very good. Now, I think this is a great case. One of the things in stroke happens, as you see more and more strokes, whenever you will hear about a case, you will say, oh, I have seen a case like that. And that is one of the wonderful things about sharing, knowledge sharing. Some things are new which you learn, but some things are, you have seen them yourself also, and you say, oh, I've also seen something like that, because there are hundreds of such patients. Now, why I'm telling you this is that I have seen one patient of acute dystonia about 4 years ago. And I reviewed the literature. In fact, I have written one article also in one book, Movement Disorder Stroke. Myself and Dr. Padma, we wrote a combined on movement disorder. But usually, as you rightly said, in acute presentation is not like a movement disorder. The acute presentation of hemichoria or hemibellismus is usually because of hyperglycemia, So, but I have seen one patient. He was a policeman and he had a very severe dystonia. And then I thought it's a rare presentation and forgot about it. But just 2 weeks ago from today, I had a 60-year-old lady who came with acute, painful dystonia of her hand. It was so painful, and the hand was in such a spasm that she did not allow me to touch it. In stroke, acute stroke never causes pain. Acute stroke will cause loss of pain. Not thalamic pain happens later on, but acute stroke. So I was not even sure, but she was very sure that it happened suddenly, it happened acutely. And the only clue was that I asked her, she didn't volunteer, but I said, do you have any speech problem? She says, yeah, there's some change in speech and there was a subtle mouth deviation. Still, I was not sure, but when I did the MRI, there was a small lacunar infarct in the putamen, which you are saying. And fortunately, in 2-3 days' time, I was thinking, from literature, I read that there is. How was the outcome of your patient in her dystonia? Did she recover? Your patient?
Definitely, he recovers. We will give a gabapentin along with all this stroke therapy,
he showed resolution of the dystonia.
Definitely, sir. Dystonia has been resolved. And the next scan show the amount of hypertensity is on a lesser side.
And when I reviewed the literature, because I was very worried that, because I knew that lady socially also, in the social circles, I knew that lady. She's a very respectable, and I was very, when a patient is socially known to us, then we are more stressed because their expectations are very high.
Very high.
Yeah. And she says, we came to you because we know only you can cure us. And patient is very well known in the city. And I was just, when I reviewed the literature, it is written in the literature, it is very difficult to reverse them. And the dystonia never goes.
Never.
And I was just wondering that I will have to give her Botox, and I already, talked to the Botox guy also. But to my surprise, when she came on the third or fourth day, and I also put her on, what do you do when the patient has painful spasm? I checked calcium and all, it was normal. But I gave her the same, what you must have given, Syneptol and gabapentin. But to my surprise, 90% of it had resolved.
Resolved.
And she says that I have now this is about 15 days, and she says that I feel little stiffness, but she is fully functional and it has gone. So we should not always be misguided by literature. Sometimes literature misguides us. Sometimes experience misguides us. So we should always approach these patients with hope, with optimism, because each patient is different. So as I see your patient, it's a mirror of my patient, which I have seen. And so thank you very much. So once again, I request the other panelists and the speakers, if they have any comments or questions, please go ahead and share your thoughts if you have any. Dr. Datta or, Dr. Jaishankar.
So when the stroke presents with a dystonia, acute onset dystonia, does it have all the classical characteristic features of dystonia, like what we see, overflowing, mirror movement, just what is the literature saying about?
No, it's not like that. When a stroke present with a dystonia, it associated with some other features, or could be a extremity weakness, could be slurring of a speech, or one of the things is like that. It has an history of a sudden onset. But the patient will rise up from the sleep, and after that he had a spasm of this type of hand. The first thing we will came to our mind, it could be some calcium deficiency, or we have to look for the calcium level. Or the other thing, after all the workup, we could not find, or somebody would label it as it could be a functional thing. The patient is doing some functional movement.
You are so right. One of my one of my colleagues who's very good, she thought it was functional. And after the MRI came, she said that probably she should not be so overconfident. In fact, we have got 2 WhatsApp groups. These days we have got WhatsApp groups for everybody. We have got at a national level, one movement disorder WhatsApp group and one stroke group. And I put that case in both the groups to share experience, but nobody had seen something like that. Now they quoted some literature. So this is extremely rare. I'm sure this must be the only case you must have seen. And I have an experience of now more than 30 years. I have seen just these 2 cases where the presentation is movement disorder, dystonia, painful dystonia.
Actually, sir, for getting this MRI done, I have to do this EEG and EMG thing myself to prove it. It is not a dystonia. I will prove it from my side.
So no, you have gone one step ahead. You have done the EEG also. That is fantastic, and you have shown there's a tremor, right? Dystonic tremor. Yeah. So I think once again, as I request everybody, I request you also to publish as a case report, and it is not necessary to publish in any JM. Forget about that. Publish it in anything which gets it published. There are many journals these days. It's easy to get published in one of these, journals. Even if they charge money, don't worry about it. You can pay that money. It is not too much in Indian journals, but at least people will see it. Otherwise, how will people know about it? See, these days what happens is that when you see some unusual presentation, you immediately check in Google. So that is how we learn these days. Nobody opens Harrison or Bradley. Now we check in Google. And what will come in Google is what is in the Google Scholar, not necessarily only in PubMed. To be listed in PubMed is difficult, but Google Scholar. And any journal which is in Google Scholar, I think it's our duty. We should report our experience, because that is how we learn. That is the fun of it also. Definitely. That makes the whole journey, full of learning and enjoyment. So I think we had a great session today. Thank you so much. We missed Meenakshi Sundaram. He must have been busy, but otherwise all 3 of you presented cases which were very thought-provoking, new, full of learning, enthusiasm. That is the advantage of having the younger generation, full of hope, enthusiasm, and all thanks to the Emcure team, and thanks to Namra Sheikh. So I hand the mic back to you, virtual mic, with thanks on behalf of all of us and the participants on this Saturday evening. So Namra, thanks to you. And
Thank you
please.
so much for providing time for this meeting, sir. It was we are extremely grateful to you for the same, and we had wonderful clinical insights from you. I would also like to thank our eminent speakers, Dr. Jaya Sankar sir, Dr. Debayan sir, and Dr. Shishir sir for the wonderful case presentations. Sir, we have a question from the audience. It is from Dr. Vipul Kumar Gupta. He says, what are the chances of intracranial bleeding with tenant place?
So any one of you can answer. I think the IV tenant place presentation, you can answer that question. Dr. Jayashankar, you presented the tenant place?
No. I presented the first case. Wait.
So anybody would like to respond? Anybody would like to respond? It is. This is less than alteplase.
That's what we can't predict actually.
You see, yeah. You see, yeah. Please go ahead. Please go ahead.
Chances of intracranial bleed in patients of tenecteplase are usually less than alteplase. It is more when the NIHS is high, age is more. If you have uncontrolled hypertension, uncontrolled diabetes, and when the patient is already on some other antiplatelet or antithrombotic, then the chances are high. Otherwise, the chances are usually less. Usually, we say around 2 to 6% patients out of 100 will get have a intracranial bleed. And among that, most of the intracranial bleeds are non-fatal. Only 1 to 2% will have a fatal intracranial bleed culminating into death.
Absolutely, I completely agree with you. Thank you.
So thank you so much. And we have 350 attendees presently who are watching. And so can I conclude?
Sure.
Okay. So soon we will be meeting for another interesting case discussion session on these No Thrombus workshop series. And then have a wonderful day and a wonderful night. Good night.
Thank you. Good night. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.